Hello everyone, let's try to solve this question together. So these labs are drawn from an infant who is now whose postmenstrual age is 34 weeks. The infant was born at 28 weeks. So infant is 6 weeks old. 6 week old. There was some history of feeding intolerance. So but now the infant is fed fortified breast milk, 26 calories. Look at the lab and what is the best intervention you guys think? Okay, the correct response here is decreasing the calorie intake. And why we are making this decision? The basic thing here was to look at the bilirubin level. Like bilirubin is high at 6 weeks of life, and direct is 1.1. So that is why these two options are given. And I'll explain in next slides that why we don't do these two things in these type of cases. And changing to 60-40 formula is not really indicated, although the FOS is high, but possibly because of higher calories. So we should first try A and see if FOS comes down. And as you guys can see that alkaline phosphatase is normal and calcium is normal. So that's why, changing to 60-40 is not an option. Now let's talk about these two, which are interesting distractor, especially at 6 weeks if you still have direct bilirubin of 1.1. So the American, guidelines state, as you guys can see, that if direct bilirubin stays above greater than 1 after 2 weeks of life, they recommend considering the hepatology and further workup. But in this case, we know there was feeding intolerance and the baby is premature and it's just borderline 1.1. So doing all the workup, I'm not denying that we should not do it, but we should just watch carefully and we'll follow and then we'll refer, because the total bilirubin is not that high. What about the British guidelines? British guidelines are little liberal. They talk about 25 micromoles per liter, which corresponds to 1.4 milligrams. So basing on that, the baby is falling below the criteria. Anyway, in conclusion, whenever you have a direct bilirubin, which is 20% or more of the total, or 1 milligram after 2 weeks of life in neonate, consider doing some workup. But again, look at the other picture. This baby was on prolonged TPN because of feeding intolerance. So that's why, we should not jump to further investigation. But at the other end, if there is no strong history suggesting of some cholestasis or something, then of course we should not ignore it. Actually, recently people are talking about even doing the screening for direct hyperbilirubinemia, and I hope you guys are aware about it. So anyway, the whole talk was just about not to overreact and looking at the whole picture before we decide about investigation. Okay, you guys have a wonderful day. Bye.